Hi everyone, I'm John from HTN and welcome to this webinar today where we focus on how digital tools are transforming community care delivery and expanding the workforce capacity. We know NHS teams are under real pressure, especially in community care. Nurses are stretched and it's harder to get more from less. So today's session is about digital tools and how they can help, not by adding more to manage, but by taking some things away. So in this webinar, you will hear from clinical leaders using tech in smart ways and in practical ways to free up time, cut administration and support safer care. So I'm really pleased to welcome our panel joining us today. We welcome Peter Cumstone, Head of Digital Clinical Systems, Safety and Transformation at Sirona Care and Health. Sarah Lowe, CHS Business and Transformation Clinical Lead at Leicestershire Partnership NHS Trust, and Gabby Cohen, Director of Delivery at Isla Health. So thank you to the panel for joining us. Could I have the next slide, please, Emily? So the structure of the session today, we'll hear from Peter, Sarah and Gabby, and they will talk us through a presentation, and then we'll go into a Q&A where that's the opportunity for you in the audience to ask any questions that you have to our panel. Just a couple of housekeeping things to cover. This session will be recorded and the HTN team will be doing a write-up so you can read or watch the session back at a later date and share it with your colleagues. As well, if you have any questions, like I mentioned, please type them into the chat. So we're keen to hear from you. Type any questions that you have into the chat, and we've got a section towards the end of the session to go through a Q&A. Right, next slide, please, Emily. So the first question that we have is actually for you in the audience. So the question is, where do you feel digital tools could take the most pressure off your team right now? So to answer that question, could you use your phone and scan the QR code and it'll take you to Slido, or type in slido.com into your web browser, enter the code that is on screen, and then it'll take you to a page and you can start to answer the question of where do you feel digital tools could take the pressure off your team right now? Right, fantastic. The technology has worked, Slido has worked, we've got one answer. That's good. So waiting lists, interesting, thank you. And we'll give it a couple of minutes for others to start answering the question. Administration tasks, administration jobs, excellent. Workflow, referrals and triage, discharge, back office, caseload management, excellent. Well, the aim of this webinar is to share practical examples that can help really. So we'll hear from work at Leicestershire Partnership and Sirona Health and Care what they have done to tackle some of these pressures. And it's going to be a real practical webinar to go through these. So there's a large theme of administration and workload. So fantastic. Excellent. Thank you for typing into the Slido. Could I have the next slide, please, Emily? And we'll get started. So we know every trust has different pressures and priorities. So we're going to hear about some of those. And could I ask the panel if they could introduce themselves, their trust, and explain to us how digital is helping moving things forward in terms of their challenges and improving workforce capacity. And if we could start with a question and the big picture of what does efficiency without compromise mean to you in the context of frontline care? So Peter, you're up first. So if I can hand it over to you, that would be great.
Lovely, thanks very much. Well, thank you and good afternoon, everyone. It's really nice to be here. I'm normally on the other side of these webinars, so it's a great opportunity and a great challenge. I enjoy not sleeping, as I said just before you all joined. But my name's Peter Cumstone. I'm a physiotherapist by trade since 2006, and I turned into a clinical informaticist or informatician because I recognised the move of digital or towards digital for the whole of the NHS, whole of life really, but within the NHS in particular, and I wanted to be a part of that solution. So I moved to Sirona Care and Health. We are a community interest company, so we are an NHS organisation or funded organisation, but we are a community interest company is what they're called. So not officially a trust, but we work very closely with our secondary care partners and primary care partners, and we deliver a wide range of things. So we've got bedded units, we've got district nursing, we've got integrated neighbourhood teams or nursing teams, we have place-based urgent care. We've got a wide variety of services that we offer. And I joined just over a year ago, so May last year, so relatively new. But in that time, we've been seeking to build our digital professionals, both clinical and non-clinical, as we seek to meet ever-increasing demand upon the digital solutions that we do offer. One of those solutions is Isla Health, and I will go on to speak a bit more about that, about how Isla Health has helped us move towards achieving our vision. In the NHS, we operate in a world of ever-growing demand, limited resources, and immense responsibility. Every minute counts, every decision matters, yet in the drive to be efficient, we must never lose sight of what defines us, and that's compassion, care, and clinical excellence. Efficiency without compromise, for me, means streamlining operations without stripping away dignity. And I know these are lots of catchphrases, but they are all very meaningful to clinicians alike. So if you're using digital tools, data, and using better workflows, it's not to rush patients through the system, but to free up time to truly see them, to listen, to reassure, and ultimately heal. On the front lines, efficiency is not just about targets, it's about making every second safer and every process smarter. I think in that slide just at the beginning, I think every single response probably goes into one of those statements there. So I think people are feeling probably the same. It's about getting patients the right care at the right time and in the right place, and making sure our teams are supported to deliver the care that is both confident and consistent. We can deliver better outcomes without cutting corners. We can build systems that work for our people, not just around them. And we can do it all while holding fast to our core mission, which is to treat every patient, every colleague, and every challenge with respect, urgency, and integrity. So let's be bold, let's be efficient, but we must never compromise care. So next slide, please. Thank you, Emily. As you can see from this slide, Isla Health was initially brought into Sirona a few years back by my colleague Neil, to support the secure storage and processing of confidential clinical images and videos. And what began as a very transactional solution where we uploaded and they stored regarding a very specific operational challenge has evolved through effective collaboration and, most importantly, trust into a true partnership. So as you can see, the numbers are increasing. We have normal variances, but it's a it's ever growing. And I think if we go to the next slide, please, you'll start to see the progress or the evolution that we've gone through. So I think one of the people in Slido did actually talk about waiting list validation. So that's what I've been brought. Well, that's what I'm going to highlight today. Waiting list validation is a huge thing for us, and so I'll let you read through the slides and I'll go through mine. As we're acutely aware, pressure across the system is intensifying, the demand on services continues to grow, and simply asking our teams to work harder is not a sustainable strategy. We need to work smarter and more collaboratively to find scalable solutions that genuinely ease pressure while maintaining high standards of care. This is where Isla Health, and in particular Lana, who has been instrumental for us at Sirona, has made a real difference. They provided a straightforward, low-burden implementation of a waiting list validation tool. Simple text message is sent to individuals on our waiting lists, asking whether they still require an appointment for their original issue. The result, in one area, waiting times fell from 33 weeks to 25 weeks, admittedly alongside other service improvement methodologies, but waiting list validation was a key one, and now we're rolling this out across additional services. The impact in total numbers will be significant. As you can see, there's 224 hours of clinical in under 4 months. It's huge numbers. Crucially, this isn't just about reducing lists. It's about supporting people to wait well. Through this tool, we can signpost individuals to self-management, resources, and community support, reframing the model from a traditional transactional medical model to one of co-production and shared responsibility. And my role in Sirona is to represent the clinical voice in all of this. So any technology we do introduce must genuinely create efficiencies, not simply shift the burden elsewhere. Too often we see solutions deployed before the actual problem is fully understood. And as a result, clinicians and administrative teams are left carrying additional workloads. That's why I wanted to share the feedback from an admin leader in our community dermatology team, a team which recently won the Innovation Award from the British Dermatological Nursing Group for their implementation and use of Isla Health, who told us that the experience with this rollout has been entirely positive. And in healthcare, that is not something we hear often. When you look at the numbers, a pathway has been reduced from 12 weeks to just 5 days in some cases. That's more than impressive. It's transformative. It's disruptive change in the best sense of the word, and it embodies exactly what we are here to discuss today: efficiency without compromise. Thank you.
Thank you, Peter. Could we have the next slide, please, Emily? And Sarah, if you are ready, over to you, please.
Hello everyone, my name's Sarah Lowe. I work within Leicestershire Partnership Trust as a business and transformation clinical lead. My background is nursing and I've worked both in inpatient and community over that time. Our trust has mental health services, community services, children's services and inpatient areas. So we cover quite a lot. We cover Leicester City, Leicester County and Rutland. So it's quite a large area that we cover as well. And we have been implementing digital tools to support clinical pathways for approximately the last couple of years. Isla we've been using now for 2 years and it's been really successful in Leicestershire Partnership Trust. Next slide, please. Oh, and the next one, sorry. So how we're using digital to in Leicestershire Partnership Trust, we are sending resources via Isla and via AirMid to reduce admin time. So that reduces time printing, time putting things in envelopes, and it also reduces postage costs. So it's got an efficiency saving and a financial saving. We're using it at the point of triage. So when a referral comes in, can we get a photo sent in? Can we get a video of the patient's environment, depending on the service? We're using it for appointment amendments. So patients don't have to then ring into our call centre, which then gets a referral to the community nursing service, or for example, they then have to ring the patient and amend the appointment. So that's got an efficiency saving as well. We're using it for videos to inform hospital discharge. So those see the home environment, and with our falls prevention service, we're going to be using it to take videos of the home environment. So that saves a home visit to just go and look at that, and then you can give advice to the patient dependent on that. We're using it in our speech and language therapy service. So they're using the voice note functionality in Isla to get that speech back from patients, and they can do those reviews of patients that way. And it's been really successful in sharing of information between healthcare professionals and promoting self-care with patients. So one of our healthcare assistants said that she can be with the patient, notice a deterioration in a wound, can contact the person that's triaging back in the hub, send the photo straight away, get the advice and do that treatment straight away rather than delay waiting. So that's another efficiency. Next slide, please. So this is for me, what I see efficiency without compromise in the context of frontline care. It's continuing to deliver high standards of patient care using different methods such as technology to support elements of the patient pathway. And that's doing that without reducing the quality that mutually benefits patients, clinicians and the service. And I'm embracing it. I think everybody needs to embrace it. It's the way to go. We've got capacity challenges, we've got workforce challenges, we've got high demand, we've got waiting lists. If you can use something that will free up a part of the pathway that means you can go to that direct patient care, it's a no-brainer to me. We're also testing the waiting list functionality to see if that improves things as well with Isla. So we'll be able to hopefully do as Peter has done, streamline our waiting lists, reduce our waiting lists and improve the access for patients. Thank you very much.
Excellent. Thank you, Sarah. And Gabby, over to you.
Brilliant. Thank you. Thank you, Sarah and Peter. I think it's always the best kind of to hear about the feedback and the insights from our clinical and operational teams. Peter mentioned Lana, who's rolled out the project at Sirona, Tayat, who's been working with Sarah and the team to roll this out, and then the incredible clinical and operational teams that we work with at LPT and Sirona to kind of get these projects off the ground. So as John said, I'm the Director of Delivery, and my team's already responsible for implementation and evaluation and making sure that kind of whatever the dream state of these implementations are, we work collaboratively with both clinical and operational teams to make sure that we can get there and get there as efficiently as possible. Next slide, please. So just to give a little bit of context around Isla itself, we work currently across more than 30 NHS trusts. We work in both community and acute settings, and we have around 200 clinical pathways, and we'll talk a bit about what a pathway is in a moment, but 200 clinical pathways where we're leveraging data to be able to move patients on more effectively kind of along their care journey. We get around 2 million submissions to the platform, so that per year, so that's photos, videos, sound recordings, proms and prems. And we have a team of 42 kind of colleagues based in London, but actually all throughout the UK. We've just started our global expansion with a deployment in Trinidad and Tobago and Ireland, kind of the most logical deployments outside of the UK. And then we're very proud to be B Corp certified and make sure that we're always kind of driving forward the business in a way that promotes sustainability and efficiency, both within our industry and broader industries too. Next slide, please. So to give a little bit of context around what we think about when we talk about Isla, we rarely think about Isla's digital pathway platform as a mechanism and a way to be able to move patients through their care pathways as effectively as possible. And what that looks like is really sophisticated automated digital pathways that leverage patient-submitted data, clinician-captured data, events and information from within the electronic patient record to understand exactly when and how we should be requesting information from patients and how that information should be surfaced to make it really easy for clinical teams to kind of move a patient to their next steps. And fundamental to this is having this shared visibility, so this multidisciplinary access to these digital pathways so that we can have teams, and we'll talk about community care and community wound care in a moment, but really being able to use these pathways to create this shared visibility and get these patients to where they need to be in their journey as quickly and efficiently as possible. A large component within this is using the Isla platform to be able to identify clinical and administrative tasks that can be automated or codified in some kind of way. So really to that original slide, we're kind of thinking about what tasks are just a function of systems that maybe don't talk to each other, what tasks are not adding any kind of value to the patient or clinical experience of providing care, and how can we automate those bits so that really each contact, each data point that we're surfacing is supporting a clinical decision that's meaningfully moving patients forward. And we do that at every step of the journey. So we do a lot of kind of referral management, advice and guidance. Both Peter and Sarah have spoken about waiting lists, and that's not just kind of understanding our waiting list better, but it's being able to signpost patients who sit on waiting lists to how they can access care, how they can kind of self-care and self-manage while they're waiting for care, all the way through into clinics and kind of doing that in-clinic assessment, monitoring and surveilling patients, post-operative workflows, for example, or longer-term monitoring, and then supporting that transition into community care. Sarah spoke about kind of discharge pathways where we're using Isla to understand what a patient's home environment looks like, to get them off the ward more efficiently, and then finally really thinking about the shroud of sustainability, which is making sure that patients are supported to self-care and thinking about what that means meaningfully within a community care setting, but also much more broadly. Next slide, please. And then running through some benefits and thinking specifically here around community nursing and wound management, what we fundamentally want to be able to do is request the right data at the right time and create the appropriate visibility to be able to make caseload management and kind of all of the admin tasks that sit around that as efficient as possible. And we spoke about this triage model, which is really kind of patients and referrers sending in images of the kind of area of concern, completing wound assessments and being able to use the information contained within that to identify the risk levels and understand the risk levels of those patients and use that to kind of support workforce planning and caseload planning. And what we've seen from that model is a 75% de-escalation of SOS kind of referrals to planned interventions, which has had a fundamental shift in the way that same-day staffing works across many of our sites. We've seen 15%, I beg your pardon, of those contacts shift to virtual, and we see that it's 3.8 times quicker to get specialist input because we have this MDT view of this data that's coming through into Isla, which is really exciting. That, of course, also translates into kind of avoided travel, which is really fundamental for meeting our net zero targets, thinking about things like printing, which Sarah spoke about, and kind of digitizing resources. And then, of course, communicating that through into what the financial impact is for organizations. Fundamentally, we need to be improving patient care, we need to be removing admin tasks, we need to be meeting our net zero targets, but we need to do it in a way that's financially sustainable for the organizations that we work with. Otherwise, there's just no way that these projects can continue to grow over time. So that's just a little bit of an insight into kind of some of the high level impacts that we've seen across many of our sites that we're very proud of over there. And then just to wrap up, Emily, if you don't mind, next slide, please. What that actually looks like is being able to use all of this codified clinical decision making to build out these automated digital pathways. And this is just an example of kind of one UI view of a lower limb kind of pathway that we have on Isla. And just to give you a sense of kind of what that shared visibility looks like. And there are many different ways that this data is surfaced and interacted with, but I will stop there so we can start taking some questions. Thank you.
Fantastic. Thank you, Peter, Sarah and Gabby. That was really insightful, and it addressed our aim that we set at the start in terms of practical examples, and the achievements are fantastic, really. So we've got some time to drill into some of those projects. So if anybody in the audience has any questions, please type them into the chat. So if you want to ask anything practical, was to explain anything again, go into any of those projects, programs, anything at all, we have about 25 minutes for a Q&A. And to ask any questions, type them into the chat. So to kick us off, I'll ask a few. So Peter, can I ask you the first one, please? You have been close to clinical and digital tools, clinical teams and digital tools. Where have you seen tech make the biggest difference to stretch staff?
Okay, I think it's a very recent piece of work for us, which is, so we're an EMIS community user as our main EPR. And very recently, we've started to move across to EMIS Mobile. And I think contemporaneous records, how people are recording things, where people are recording things, it's a huge challenge for us. We are out in people's houses, we are outside of bases. We're not based in wards and nice clinic areas where you've got computers on wheels and you've got desktop set up and ready. So the ability to record contemporaneous notes is a huge challenge for us. I was community worker myself. I remember the days of carrying around 10 sets of notes, massive files of notes, carrying around and sitting in my car and writing them. Or we've all seen the newspapers of people sitting in coffee shops with patient medical files out. And so the move to EMIS Mobile, it's relatively recent. I think we're only up to about 50 users at the moment. We're in our phase 1, phase 2 of rolling out. But it's just the ability to have things on phones. I know Isla Health is on our phones and we are using it, but I think our main EPR is EMIS. So for us, it's the ability to put clinical records in clinicians' hands where they need it. And I think all three of us talked about the right information at the right time, just the ability to treat patients with the right information, or just having the right information to make the right decision. So the move to EMIS Mobile has been massive for us, because otherwise we're carrying around bulky laptops, which it take as long to load as the appointment might have taken. So it's a small step in terms of what we're used to on our home lives, but from an NHS trust and from the way that the NHS works, it's a massive step forward. And I think we've got to that point by listening to what our clinicians want and what the problems are, rather than saying we've bought a new solution, here you go. It's people saying we really struggle to load our laptops in patients' home or in our cars or wherever we might be sitting. And that's driven the revolution, rather than us saying, well, we've bought EMIS Mobile, now you're going to use it. So that's where I think it makes a difference, is listening to clinicians. And that was the purpose of me coming in as a clinician, was to bridge that gap between IT and clinicals, because we are ultimately all trying to do the same thing. So it's a really powerful tool to sit next to people and say, I get it, I understand, this is what we're going, this is the solution we can offer. And Isla Health will be brilliant in terms of what they offer as well. So I think that's been the biggest already stretched staff. It's not adding a burden, it's making their lives easier.
Thank you, Peter. And Sarah, leading on from that, I'm sure that's the reality for you, but where do you feel the pressure the most, and how can digital tools help ease that pressure?
I think for every service, there's a massive demand on services now. And sometimes the capacity to meet that is a real challenge. So digital tools could help. I think it's like I said earlier, for example, at the point of triage, you can use it, and will that determine your response time to a patient rather than that knee-jerk reaction? You get that written referral, you go out based on that, you can do a bit more of an assessment of what you actually need to do. Or for the other example I used with a healthcare assistant who was in a patient's home and could use Isla there and then to get a response and do that treatment quicker for the patient. I think it's like Peter said, you need to listen to the staff and what they need. It needs to be easy for them to use. And the beauty of Isla is it's very, very straightforward. We had a previous solution that was quite complicated, quite complex. You then had to connect your phone up to a laptop to download it. You don't need to do any of that. We've had challenges in community nursing implementing technology in the past. Isla has been one of our biggest successes. They absolutely love it, and they're coming up with new ways that it can be used. So triage, when we do our self-care project, we've had lots of ideas from that hub on how it could be used to support self-care pathways and triage. So I think it's got to be easy for staff to use. It's got to be the right thing as well. You can implement things and they're the wrong thing. Test them, because testing can get you the right pathways to use it on, rather than just throwing it out there. So we've rolled it out slowly across community nursing. We've gone hub by hub, learned from that one, gone to the next one. We've had great support from Tyat. She's been absolutely brilliant. She's definitely part of our team here. But yeah, that's for me. It's the demand, the capacity, but also having things that are easy to use so that it doesn't become cumbersome. We did use another app. All of the patients were asking staff, how do I download it? How do I use it? That then increases the amount of time they're then with the patient. So it didn't actually fulfill what we needed it to do.
Fantastic. Thank you, Sarah. And Gabby, we've had a couple of questions in the chat about integration with EMIS and TPP System 1. Could you, is that possible, and how does that work?
Yeah, absolutely. So we have native integrations with both EMIS and System 1. And actually both Peter and Sarah have inputted on the design of those integrations at various points. EMIS actually across both pull patients into Isla automatically. So as they're added to a waiting list or as they're booked into a visit, they're pulled into Isla. So there's no data capture over there. And then we're also pushing data that's captured through Isla back into EMIS and System 1. So we still have a consolidated patient record. So really making sure that we kind of ensure that single source of truth, and ensure that clinicians that maybe don't have access to Isla still have a way of seeing any data that's been captured as a part of this. One of the things that I think has been a nice benefit of that is there's no manual upload into S1 or EMIS, which is kind of what some of the challenge was previously, of having to capture that on a mobile phone, upload back when you have kind of internet connection, and I'll talk about that in a moment. So that's certainly one element from an IG perspective, is anything captured through Isla goes straight into Isla, our cloud-based environment. It goes straight into the EPRs. Nothing's stored locally on the clinician's devices, so you don't have any mobile phones bobbing around with lots of kind of sensitive patient data. Something that's come up recently, and that one of Sarah's teams is actually trialing at the moment, is offline access. So these integrations are great and they allow that kind of consolidated view that I just spoke about. But what we were missing is when you're in these kind of dead zones, these Wi-Fi limited or connectivity limited areas, which many of our clinicians who are going out in rural areas might experience, there's no way to kind of access the internet, and that can cause different limitations to uploading data. So very excitingly, we've released our offline access capability, which Sarah's team's in the process of testing for us and giving feedback on. And that's going to allow us to have kind of improved coverage over all of these areas. So fundamentally the EPRs, but also making sure that we're catering for local needs of different teams from a tech perspective.
Excellent. Thank you, Gabby. And Peter, can we talk about safety and safety with digital tools? So how do you make sure digital tools are safe and support safety and consistent care without adding to any complexity?
It's a very good question. And I think as anyone who's involved in digital clinical safety, so there's a new role now called a digital clinical safety officer. So there's training. So I'm designated one of those for Sirona. we are an ever-growing bunch of individuals who are clinicians, but with a digital interest, and it's vital. I mean, record keeping healthcare, it's all based upon, or good healthcare is based upon what we record, how we record it, and the systems have to be safe in which we do that. So without going over too much of the boring detail, there's something called the DCP standards. There's a 0129, which is on the supplier, and then there's a 0160, which is on the implementing organization. And basically, there's a hazard log. You consider risks. You consider where risks sit for mitigation. So is it on the person? Is it on training? Is it the system at fault? So there's a whole heap of work that you do alongside suppliers of EPRs, apps, anything that you are using for healthcare management. That's the framework and the structure on which it works. The reality is, I think we spend a lot more time working with our clinicians to find out those on the ground problems, and then we raise them quickly with Lana in our case, and with Gabby, and fixes are then released. I think it's a really important, as solutions evolve, it's our job to check that they're evolving safely, and things which may, and that's the efficiency without compromise is an absolutely key bit, is that we can make the workflow easier, but if it compromises the quality of the data, the quality of the outputs, then sometimes things take time, and I think that's a really important balance to be struck. And that's where good partnership working, so I know Shona, my colleagues on the call, we spend a lot of our time with our colleagues out on the ground to say, this is the change, this is what's coming, does it work, does it make things better or worse? And then that drives what Gabby and her team deliver. And I think it's symbiotic, it's got to work together. Very often, technology companies may think this is the best thing, but in reality, I think Sarah's saying the same, is that in reality, does it actually make the difference that what was on that whiteboard in an office 6 months ago, when it hits the ground, are we using it correctly? So clinical safety is a massive thing for us. And something I say, and I say it flippantly, and I apologize for that, but I want the conversation now, not in court. And I stand by that mantra. And I know it seems a little bit dramatic, but it's really important. At some point, our notes are going to be read back to us, and this was available, this information was available, why didn't you use it? So I take clinical safety very important. I don't want it to get in the way of healthcare, but there is a fine balance to be struck. So yeah, I think if you don't know who your clinical safety officer is, go and find them and contribute, because they'd be grateful for your input, your clinical input or your digital input or any input, because I think a single person reviewing a whole system is difficult, but as a team, we can do it much more effectively and get a number of viewpoints. Thank you.
Well said. Thank you, Peter. And Sarah, following on safety and simplicity, is there a moment that you could share where digital has made something simpler or more safe, either for patients or your team? Could you share an example of how it has, please?
Thinking off the top of my head, we've had a patient in our pilot that we did who had a non-healing wound, wasn't very engaged with his care. The team spent a lot of time showing him how to use Isla. He took it on board. He then wanted to share a photo every day with the hub, which they said wasn't quite necessary. But he came off the caseload very quickly after that. He'd been on the caseload for a number of weeks, not healing, but because of that engagement and his ability to have a bit of ownership over his care, he's now off the caseload. And then with a colleague in our podiatry service, one of the patients had a suspected infected wound. It was actually an EMIS practice. They were able to share the link with the EMIS practice with a one-time password code. GP had a look at the wound, prescribed the antibiotics there, and then so the patient was treated very proactively, rather than that delay, getting back, trying to get through to the GP, then trying to share the image with them or taking it to show them. So there's two examples there. It's been good for both patients and for staff.
Absolutely fantastic. Thank you, Sarah. And Gabby, can I come to you to talk about digital projects? So we hear about lots of projects and programs, and some struggle to get off the ground. What has helped you here move from idea to realizing the benefits and impacts of a solution?
Yeah, absolutely. So I think, anyone who's attended any of these that I've done before is going to think I'm a broken record, because I do stand by kind of the core elements of this. And I think one of them certainly is having really robust and rigorous implementations that consider the down and upstream impact of what we're doing. And that's everything from integrations and the technical ecosystem that we're talking about. And then kind of to Peter's earlier point, what are the downstream, upstream impacts of the change that you're making? So really mapping, and what that looks like in practice for us is pathway mapping, really understanding the problem we're trying to solve, understanding who's involved, who owns different parts of that. The second thing is making the solution as simple as possible. So usually if you can't articulate your solution very simply and you can't really give that one-liner summary of the thing that you're doing, you probably haven't really got there in terms of the transformation and change that you're trying to implement. So keeping it really simple, and you get a lot of buy-in by doing that. And then I think the final thing, and something that we've really experienced at both Sorona and LPT, is having people in the project group that are empowered to say yes. So when we think about things like security and integration and safety, having the tools to apply that rigor, and once those standards have been met, kind of reflect that, acknowledge that, and be able to move the project forward, and really having empowered members of the team who can say, yep, we've met these standards, we can move, we can get it to the next stage. And that allows us to maintain the impetus of actually getting something that is ready to go, that's mapped out, that looks beautiful, the integration's all there, into kind of a mobilized, real and realized day-to-day practice.
Excellent. Thank you, Gabby. We've had a question in the chat. Sarah, can I come to you for this one? In terms of what strategies have you found most effective for getting clinical buy-in when introducing a platform like Isla?
I just saw that. I was just about to answer, actually. So in my team, I had a member. There's 2 clinical staff within my team as well as admin staff, and one of the clinical staff was identified as the lead. So she actually worked in the team basis and was there. She delivered the training to staff in a session, but was also there for troubleshooting, guidance, if needed to go and be with a patient and actually use the tool in practice. That has definitely helped. It is a little resource heavy, but it has benefits in the long run, and it's been fully implemented across community nursing. It is absolutely embedded within practice. So we could have done it a different way by giving resources and doing it remotely. I think it would have taken longer, and I don't think we would have had the success we had.
And Peter, same question for you. How have you achieved clinical buy-in?
Fully echoing what Sarah just said. I think it's articulating the problem, getting alongside people. So, I mean, physiotherapy is a classic example. Physiotherapy is something you do rather than something you get. And I think that's what it's the same for digital, is that if we just go out and buy things and turn up at somebody's door and just say, here you go, and walk away, it's inevitably going to fail. So I think the most recent evidence is 70% of digital transformations fail. 70%. That's billions and billions of dollars, according to the latest research, fail. And I think my new boss, my chief digital information officer, said, and this isn't referring to Isla, so a bronze solution implemented well is better than a gold solution implemented poorly. So, and I think, not saying Isla's a bronze solution, that's, take that back, but it's all about the implementation. You can have the world's best solution, and if you don't get alongside your colleagues, alongside your patients, and make it fit their workflow and make their lives easier, it will fall. People will find every reason to walk away from it. So I think that's been the strategy. And again, going back to my colleague Sean, who's also on the call still, is that we spend time with our colleagues, we get to know them, we get to build that relationship. And I think that's what's been so important, is we build a relationship with Isla, but we build it with our board, we build it with our clinicians. We are definitely translators or bridges, or however you want to describe us, in terms of bringing those worlds together, because clinicians are busy, salespeople are selling, boards have got other priorities. It's how we bring all that together into a coherent space that allows us to deliver. And the proof is in the pudding. That the lady I referred to in our dermatology team, who won that award for innovation, that's an a national award. It was over in Ireland. It's a huge award for innovation. Now that's a massive win, and seamless, painless implementation. That's those are phrases we don't hear that often. So not only has it made their lives better, they've been recognised on a national scale for it. So I think that's a huge bonus for us, and I think something that we seek to replicate. But in terms of the strategy, get alongside people, floor walking, everything you've just said, Sarah, is really important. You know, remote watching videos, you can watch videos, but having someone next to you to problem solve on the fly just makes things stick so much more easily, and you get more confidence, and you can remove that support far more quickly than things taking a lot longer. So yeah, everything Sarah said basically. Thank you, John.
Thank you, Peter. And we've had a question in about how did you both start? Did you start with a pilot or a large-scale implementation? So Sarah, can I come to you? Could you provide some background into how you started?
Yeah, so we started off scoping we wanted to look at green photography initially, and we started scoping the various options, and Isla was our preferred option. And we worked with Gabby and Tayat. I did a pilot in community nursing, our community hospital ward, podiatry and lymphedema. And based on the outcomes of that, we then put a proposal forward to have this substantively in our directorate, and we're now thankfully successful with that, and it is rolled out across our whole directorate. But the pilot was brilliant. It's not long. You don't need a lot of time to do it, so it is quite a quick pilot. We did it over 6 weeks. Had fantastic results that were evident that could be seen across the trust. And then, yeah, we've gone through over the last year and done a bigger rollout.
Fantastic. Thank you, Sarah. And Peter, how about your organisation?
Again, absolutely echoing Sarah's thing. I'm not doing this on purpose, I promise. But again, Isla were brought in to look at the safe storage of safeguarding secure documents and images and videos. And as that relationship blossomed, we talked about evolution. We moved. As Lana got alongside us, she got to see more of our problems. So actually, we got a solution for that. So it was more iterative in terms of its rollout and use. But generally, we do start with one team, and then as soon as we start demonstrating the benefits to one team, other teams are, champing at the bit. I was getting confused whether it's trumping or champing, but they're ready to go. People want it, and I think that also drives adoption of technology, where people see it working, recognize a problem in their area, and say, actually, we've got a solution and we can just roll it out. I think one of the questions is, yeah, Lana does offer hours training. I don't know if that's officially offers training, but she comes out, sits with our teams, offers training. But again, if the system is easy, the training is minimal, and I think that's a really important part of it. It's people just pick it up and use it, and it's not quite self-explanatory, but not as close as you can get to being self-explanatory that you can wish for. And I think, yeah, that's what I was saying. Thank you, John.
Thank you, Peter. The next question's a technical one. So Gabby, can I come to you for this one? It's how long does it usually take to integrate Isla with a new EPR that doesn't have an existing connection?
Yeah, this is a great question. So my team, and part of kind of what we do in delivery, and part of the planning for mobilization, is to sit with whichever trust or organization we're working with to understand what the technical and operational and clinical requirements are of the pathway. And a huge part of that is the interoperability mapping of how do we make our system speak to your system, and what are the kind of various data fields that need to be going back and forth to make this as useful and efficient as possible. Where we don't have existing integrations like System 1 or EMIS, often we'll leverage things like HL7 or FHIR, so some kind of standardized APIs. We also have our own API that we've designed that partners can kind of plug into to interoperate with us or to connect with us. But essentially, the process looks like us sitting together, doing that mapping exercise and understanding which tool works best. We have one kind of in flight right now, and I'm not sure if we're talking about it yet, but in certain circumstances, we will go direct to the provider of that APR and we'll work with them to deliver the solution. Those tend to take a little bit longer. I think the most recent one we've done, all work was done within 3 months. And then there was some witness testing that we had to go through because we're working with a third party. When it's just kind of on our side, if the trust already has HL7 capabilities or has connected via a trust interface engine, for example, that can be as little as 2 weeks.
Fantastic. Thank you, Gabby. Right, the next question starts with a comment just to say thank you for sharing what you have so far. I can see this is a game changer for consultations. So the question is, may I know how patients are engaging, and especially the elder population? How are those patients engaging? Peter, can I start with you for that one, please?
Yeah, I think, again, echoing Sarah's point in the chat, I'm being quite second-handed here. Very sorry, Sarah. I think it's not as bad as you would imagine. I think digital exclusion is always a risk in any tool, in any, but my colleague who was in his 60s when I was working on this said, be careful that you say that it's all old people. We watch people of all ages struggle with technology. So it's an interesting challenge. I think historically, my grandpa was in his 90s, he was using his phone to do things, so it's not all. I think we need to be aware of that. I think, as I replied, I think we had an 80% response rate to our last waiting list validation of thousands of patients. So most people got back. Those that didn't got a letter or a phone call follow-up. So we make sure that no one is left behind in moving forward with this technology. But it's an important question, and I think one that we are tackling quite well. I think any one, if you only have one solution, you end up isolating some or excluding some people. So I think we are very careful to make sure we offer phone calls, texts, letters, whatever that might be, through proxy contacts. It's all about consideration. We consider it and we manage that risk because we don't want people to get left behind. I think it's particularly within Bristol, North Somerset and South Gloucestershire, we have a huge language variation, hundreds of languages, not quite hundreds, probably 100 languages are spoken. So how do we get around that? So we're looking at translation services and automatic translation services. So it is a problem worthy of consideration, because if we're going to be truly equitable in the health service we deliver, we need to consider how people enter our service, how they're treated and how they're handled afterwards. So great question, and hopefully one we're sorting well. Well, I think we work very closely with our patient engagement and experience lead, because we might think we're doing well. We need the answers to come back from those areas of the city that may not be well served. So we're working hard to get feedback on how we think we're doing. Thank you, John.
Great. Thank you, Peter. Sarah, can I come to you for the next question? What's one thing you think digital tools should always do for community teams, and one thing that they should never do?
I think it goes back to about the efficiency without compromise, and where I said that it's about the ease of use for everybody. Isla is a very easy platform for both patients and clinicians to use. I think the beauty of it for patients is they get a link, they click on the link, they submit what they've done, their bit's done. Actually what Pete's just said about younger people is very interesting, because my son can't engage with technology at all. My dad, who's 81, absolutely loves it. So I think you're right, Pete. We do need to be really careful about that thing about only the older people struggle with it. I think it needs to be easy to use. It needs to not be clunky, and it needs to do what you want it to do. That's where you lose engagement, where it doesn't deliver what you promise it will deliver. So it goes back to what I said before. It's about supporting elements of the patient pathway, but that mutually benefits patients, clinician and the service.
Fantastic. Thank you, Sarah. Gabby, question for you. How do you ensure that the data gathered through digital systems translates into actionable insights that's meaningful for frontline teams?
Yeah, great question. Thank you. So I think both Peter and Sarah have mentioned Lana and Tayat, members of our team, and it's worth kind of reflecting on the role of the delivery team for a moment before I answer that question. So the purpose of the delivery team is to really act as an enabler for that implementation. And I spoke about kind of the technical mapping, but a large component of this is also pathway and process mapping, and understanding what the as-is process looks like, and what the kind of intervention and change should look like, and what KPIs or what indicators we expect to move as a result of that change. What we often find is that sometimes the first step is incorrect, but what that exercise allows us to do is really understand where there are existing blind spots within the service. So actually, when everyone sits around a table and tries to map it out, you realize maybe you didn't fully understand what was happening at certain parts of the pathway, but it also allows us to understand what we should expect that impact to look like within the service. And that allows us to create the blueprint of when and why we're requesting data. And fundamentally, we don't want to have kind of this barrage of information of photos every day if that's not useful or insightful for the clinical teams looking after patients. So this pathway mapping process is pretty instrumental for us in understanding when we're asking for data and why we're asking for data, and then how we want to surface that rather to our clinicians, so that it's as intelligible and useful as possible. The final thing to mention there is that it is very iterative. So we might learn something about the pathway as we're implementing. We might understand that there's an additional data point that we want, or one that's not very valuable, and then kind of tweak and change these pathways as we have the feedback from data, from clinicians, and from our patients to understand how these pathways should be changing. So the team kind of continues to work with our partners to make sure that we're iterating really effectively and getting to something that is as close to, in an ever-changing environment, kind of effective and efficient as possible.
Thank you, Gabby. And Peter, can I come to you looking ahead? So where do you see the biggest opportunity for digital and community healthcare in the next 12 months? So in the short term, not 5 years, and in the immediate 12 months.
I don't know where to put my hat on this one. I think for me, I think we need to concentrate on that shared care record. I think we, certainly within community, we face so many different directions. We talk about the single source of truth or single patient record. If social care are missing, if police are missing, if there are so many components to an individual's, not just care, but their lives. And I think that's what if we focus on a health perspective, we miss the socioeconomic impact on health. We miss their educational needs and requirements. So I think that's where that's where I'm going to put my eggs in that basket. Is I want a better shared care record where information is available. And not, there is a challenge around too much information. How much do we share? And I'm not proposing we share everything, but a summary of people's requirements from different areas would be just a superb start. So I know that's not particularly digital and modern, but I think it is enabled by digital players and by our solutions that we have. I think we, certainly within Sirona, and I've come across from Wales, we've got a number of solutions, legacy systems, as they're known, in terms of things that don't talk to each other. So I've got an example of an OT colleague who had 9 different systems. She was in a psychiatric unit, but 9 different EPRs. She had to go and look for information about her one patient, and that just adds burden to that individual. So technically the information was available to her, but only if she went and logged into 9 different systems. And the fun example I use is, I'm, again, physiotherapist. Our blue notes are at the back of the paper record. You'd have doctors coming up and saying, I can't find your notes. They wouldn't even flick to the back of the paper record, let alone log out of their system and go and log into another system. So even though my request is a story as old as time, I think digital has a place to play in that. So whoever's on this call, whoever's listening, challenge your digital leaders, your local authority to share that information and not be scared. We should be scared of handling people's information, but be willing to share it. So that's what we're concentrating on, certainly within Sirona, is the availability of adverse reactions, allergies, drugs, things that are standard across many places, just the ability to share and get a better rounded picture of our patients and deliver better. So my phrase is clinically led and patient focused. That's the plan. Thank you, John.
Excellent point. Thank you, Peter. And Sarah, can I ask you the same question? The next 12 months, where do you think the biggest opportunity is for digital in community care, or perhaps what's on your roadmap at LTP?
I think the waiting list validation work that we're doing, and then the self-care work that we're doing. I think self-care has got so many opportunities. I think it's not something we all particularly do very well. We don't do consistently. Something that's come out of the pilot that we've been doing with Jack at Isla and with Gabby in one of our hubs has shown that we don't consistently approach it. People all do it slightly differently, but there are massive opportunities with self-care for patients.
Fantastic. Thank you, Sarah. And Emily, could we go to the next slide, please? So we have another poll. So I'm keen to hear from you in the audience. So from today's session, how do you feel most motivated to explore digital improvements in your own service? So it's the same Slido again. If you scan the QR code, it'll take you to the page to answer the question. Or if you type in slido.com and use the code, it'll take you to the place to answer the question of where do you feel most motivated to explore digital improvements in your own service? So keen to hear from you in the audience on this question. And we'll give you a minute to do that. While people are doing that, can I ask you a question, Gabby? We've had one in the chat. Is this an off-the-shelf solution, or can it be customized to meet requirements?
Yeah, absolutely. I was just typing out a little response to that. So the platform, the functionality is off the shelf, but the way that it's configured and designed to solve the challenges of a specific pathway is completely unique to the case and like local requirements. So our job is to understand exactly what the problem is and which elements of the functionality can be used and how they should be used to solve that problem. So there's tons of kind of local configuration, and we work hard to make sure it serves whatever the accessibility or specific requirements are of that local population.
Fantastic. Thank you, Gabby. Right, we've had some answers into the Slido around reducing unnecessary face-to-face visits and helping preventing falls. Fantastic. Right, excellent. So we've only got a couple of minutes, so I'd like to ask the panel one more question. If you could provide one key takeaway from today's discussion, or one piece of insight you'd like the audience to go away with, what would that be? And Peter, could I start with you for that, please?
Yes, I had a really nice answer written to this, and now it's completely gone out of my head. But I think digital is a tool to enable better care, and I think whatever we do, if we're putting the patient at the centre, their lives will be made better. And it's not always about a better outcome, because sometimes people die, but their experience. And that's what I want to focus on, is that digital needs to support clinicians and admin and anyone around them and people's self-care to access healthcare and have a better, higher quality of life. So if we keep that at the centre of all we do, we won't go far wrong.
Thank you, Peter. And Sarah, one final takeaway from you, please.
I agree with Peter on that. I think it's wrap it around the patient, but also listen to what your clinical staff are saying, because they have amazing ideas, thoughts, things that can be changed in the process. They're the staff that are delivering the care every day. So it's about that engagement with them as well. But I absolutely agree with what Peter just said.
Thanks, Sarah. And Gabby, one final takeaway, please.
Yeah, absolutely. Something we've really learned from kind of all the different project groups that we sit on across our 30+ trusts and other organizations is that having members of the team who really feel empowered within each of their remits to push something forward is really fundamental. So when we're thinking about who needs to sit on that team, it's also worth thinking about what they have to be able to do, and then give people the space and the opportunity to actually do that. And we see teams excel kind of when they have the opportunity to do that.
Excellent. Well said. And we've only got a minute to go, so I'll look to close the session here. But to reflect on the first Slido, the first question where we asked about pressures, it was around administration, workflow, workforce capacity, waitlist validation. And I think you have clearly demonstrated that through the past hour in terms of practical examples and how you've achieved that. And there's been some great statistics, and I think you should be really proud of what you've achieved in both of those projects. And it's been a pleasure to hear about them today as well. So I guess thank you for joining us, and well done to you. And thank you to everyone in the audience for joining too. I hope you found this session useful. I'm sure you have. We will be doing a write-up so you can reflect on some of the discussion points and just take some time to reflect on what's been said over the past hour, because we've gone into quite a lot. And as well, if you like, you can watch it back. The recording will be shared, and that will be shared in the next, I think maybe this afternoon or in the next day or so. So you could watch it back if you want to as well. So that's everything. I'll close the session here. Gabby, Peter, Sarah, thank you for taking the time out of your day to join us. It's been a great session. Thank you to everyone in the audience, and have a nice day, everyone. Thanks, everyone. Cheers. Bye.